It is very important to take into account that not everything what looks like initially keratoconus, it is actually keratoconus, since we have available several devices that are able to provide us with OCT technology, epithelial and stromal maps. We have been able to identify many cases that despite if we use only the anterior maps and the anterior curvature maps looks like keratoconus, they're actually not. And that points out the relevance of having available devices that could supply us with epithelial and stromal maps throughout the cases what we call pseudoectasia. There are cases that in the past were obviously keratoconus, but today we know that they are not, because they do not fulfill the whole criteria of keratoconus, and it's just other disease that is masking the anterior curvature. So in the following video, Dr. David Teren is going to show us one of these cases of pseudoectasia, some case that many years ago could have typified as keratoconus, but today we know that they are obviously not, and then they can have an alternative treatment with very good outcome. Please go ahead.
Hello, my name is David Teren. I am a fellow at Visum Hospital in the Cornea, Cataract and Refractive Surgery Unit. Today I'm going to talk about a case of Pseudokeratoconus. Let's dive into the case. A 50-year-old patient came to the clinic complaining about dry eye symptoms, photophobia, and headaches. The visual acuity is in correction. With the right eye it's 0.1 and in the left eye it's 0.6, and with correction 0.24 and in the left eye 0.88. We can see in the right eye that the refraction is minus 4.5 diopter of astigmatism in 105 degrees. On slit lamp examination, we observe the appearance of paracentral epithelial hyperplasia in the right cornea and inferior epithelial hyperplasia in the left cornea. Aside from these findings, no other pathological abnormalities were noted during the examination. The next step was performing a tomography. At first glance, it may seem like another case of keratoconus, but a closer look at the findings reveals something different. Here, on the sagittal map, we can observe inferior stiffening with irregular and asymmetric astigmatism, as well as high K values. On the pachymetric map, we noticed that there isn't any corneal thinning. The value around the area of stiffening are over 600 microns. On the posterior elevation map, we do not see any posterior elevation which correlates with the area of the stiffening. In this slide, we focus on the epithelial map, where we can see thinning of the epithelium over the area of the stiffening. Here we can see the tomography of the left eye. As you can see, there is no abnormality and it's quite different from the right eye. Our next step in the diagnosis is performing anterior segment OCT. In the image, we can see subepithelial hyperplasia. You can notice that the epithelium is thinner above this area, while the thickness of the stroma is preserved. Let's summarize. On the right eye, we can see inferior stiffening with epithelial thinning, with no thinning of the stroma and no posterior elevation. In the anterior segment OCT, we can see hyperrefractive hyperplasia subepithelial with no significant thinning of the stroma. On the left eye, visual acuity with correction is 0.88 with no significant findings. The patient is scheduled for a correction of the irregular astigmatism using an excimer laser assisted by sodium hyaluronate in his right eye. So what is a correction of irregular astigmatism with excimer laser assisted by sodium hyaluronate?
Published by Alio and colleagues in 2001, correction of irregular astigmatism with excimer laser assisted by sodium hyaluronate. Sodium hyaluronate form a stable uniform coating over the corneal surface, effectively covering the areas that needed to be protected from the laser. The Excimer laser can ablate the corneal tissue at the exposed spots, while the area covered by the sodium hyaluronate are shielded. Fluorescein dye is added along with the sodium hyaluronate. It allows the surgeon to visualize and monitor the laser in acting. Here you can see the procedure is being accomplished. This is a slit lamp image from post-operative day 1. Here we can see the anterior segment OCT on the post-operative day 1. The bandage contact lens is visible, the hyperplasia has disappeared, and the stromal thickness is preserved. The visual acuity on day 30 post-surgery is 0.4 without correction, and it improves to 0.6 with correction. Thank you for your kind attention.